Howdy. Hello, everyone. Aaron Boster here, and thank you for learning about MS with me. It's March, and it's MS Awareness Month, and I am committed to jumping online to live stream and to bring you MS awareness. It's my goal to help educate, to help energize, and to help empower people impacted by MS. And so today, I am jumping online, hopeful that I can interact with you guys. And here's BK Holly saying, yeah, live on a Friday. That's exactly right, BK Holly. How are you doing? There are 31 people jumping online right now. Howdy, everyone. Darla is on. Hello, Darla. It's great to see you. I hope that you and your family are doing well. Julia is online from Nicaragua. Leslie is here from Australia. I've got Katie here from Wales. I've got a Total Chaos Homestead. Natalie is online. Hello, Dr. Boster. Hello, Natalie. I've got John Scarpino online from Michigan. As many of you are familiar, when you jump online, please share with me where you're jumping online from. I love to hear about this online community, this global village of people impacted by MS that band together to educate, to energize, and to empower people impacted by MS. And that's what we're trying to do today. Just to give a couple other shout outs, I've got Ebby from Kentucky. I've got Janice from Pittsburgh. I've got Bruce Owen online. Hello. Hello, Catherine. Hello, Ashley. Hello, Elizabeth. Howdy to Carla. This is really, really cool. I love the fact that there's this growing online community. It means the world to me that I can pop online and say hello, howdy, hi. I'm actually in Chicago this weekend celebrating St. Patrick's Day. We're looking forward tomorrow morning of seeing the river turn green. We came here last year for that event, and it is freaking neat. I'll probably live stream that, guys. So if you've never had a chance to see the river turn green, I'll live stream it on my channel. Now, I jumped online today with the intention of talking about a very serious topic. And there's a lot of serious topics in MS, but this is one that isn't discussed enough. And that is the topic of therapeutic inertia. So before I begin explaining to you what I mean by therapeutic inertia, for those of you that are jumping online, like 1 gram, Stella from Petersburg, if you're familiar with therapeutic inertia, let me know. Write in the comments that that's something that you've heard of, or if it isn't something that you've heard of, I want to know that also. So leave a comment in the chat and let me know if therapeutic inertia is something that you're familiar with or not. Therapeutic inertia causes people with MS to become disabled. Therapeutic inertia causes people with MS to lose their jobs. Therapeutic inertia puts people in wheelchairs. It is arguably one of the biggest leading causes leading to disability in MS. And as I see in the chat, most people have never heard of it. I've got April that says I've never heard of it. Shez says that she's never heard of it. I've got Annette who says, please explain. Born Again Farm Girl from Illinois says, I've never heard of that. Diana says, I've never heard of that. And it makes me feel reassured that this is something we should be talking about, because I want everyone on this channel or who interacts with this channel, who is a member of this global community, to be sensitized to what the hey is therapeutic inertia. So let's jump in. Now, Darla's heard of it. Darla, I'm glad that you have and support me tonight as we talk about therapeutic inertia. All right, so let's break it down after I have a swig of water. That was really good. So inertia, the word inertia is a physics term, and it means that a body that is in motion, something moving, wants to stay moving. That's what inertia means. And a body at rest doesn't want to move. So if you have a giant boulder and it's just sitting there, it doesn't want to move. And getting that boulder moving is really challenging. Now, my dad, Charles, is online. And his wonderful wife, my stepmom, Karen, is online. Dad and Karen, I love you. I hope that you're doing well. And thank you for jumping online. Dad, tonight I'm talking about a really intense topic, therapeutic inertia. So thanks for joining in. And thank you for everyone, including Nadine from New Jersey and Christina from Cardington, Ohio, for joining in. but we're talking about therapeutic inertia. Now, I just shared with you that in physics, the term inertia means that if something is at rest, it doesn't want to move, all right? And therapeutic inertia deals with the lack of change despite evidence that you need to. So this was a term born, I think in the very early 90s or late 80s, out of the cardiovascular literature. And there's a situation where someone has elevated blood pressure and they're started on a therapy. So they're started on a medicine for elevated blood pressure, like a beta blocker. And they come back to their doctor's office and they check their blood pressure, and guess what? It's still elevated. So here they've been treated for elevated blood pressure and they come back and it's still elevated. And then no changes are made. So we know they have a problem. We know they have elevated blood pressure. We've put them on a medicine to treat elevated blood pressure and it didn't work, and then nothing changes. That is therapeutic inertia. And therapeutic inertia is rampant. I mean, it is a major, major issue in multiple sclerosis. I'm talking about a situation where we identify that a person impacted by MS is not doing well. They're getting worse. They're having an attack. They're having new spots on their MRI. They're failing the litmus test of life. They're developing neurological disability, and yet nothing changes. That makes me really, really upset. It drives me bonkers. I can't stand that, guys. It makes me so upset when there is therapeutic inertia, because if you are on a medicine for MS and you're having breakthrough disease, you're having clinical attacks, you're having new spots on your MRI despite taking medicine, that's not okay. That is evidence that what we're doing isn't working out. Let me give you an example. Imagine that you're on a birth control pill. So every day you take a birth control pill and you are sexually active and you become pregnant. Well, guess what? It didn't work. And the same thing applies in MS. If you're taking an MS medicine and you have breakthrough disease, that's evidence that it didn't work. And therapeutic inertia is a situation where, despite the fact that we've identified breakthrough disease, that it's not working, nothing has changed. Now, guys, therapeutic inertia happens a lot. I mean, like a lot. I mean, like all the time. And after you watch this live stream, I challenge you to look for therapeutic inertia, because you're going to see it all over the place. There are 3 groups of people that are really culpable for therapeutic inertia. There are 3 groups of people that are really to blame for therapeutic inertia. And I want to talk about each group. So the first group of people that are culpable, that are sort of causing therapeutic inertia, are patients, people with MS. And I am not pointing fingers and saying that they're naughty or bad. I'm just telling you the reality of the situation. And I want to kind of break that down and explain why. And it's not because people are not smart. It's not because people are lazy. That's not it. There are other reasons, and yet it's still happening. So follow with me. There are people with MS that struggle to get on a medicine. The medicine is expensive, and they have to go through hoops, and they have to go through insurance, and they have to go through assistance programs. And finally, after months and months and months and months, they get on a medicine, and they take the medicine, and then they have an attack. And they know that if they tell their doctor they've had an attack, that doctor might change their medicine. And so they minimalize their symptoms. They don't fully express the extent that they've had bad things happen, that they've had breakthrough disease. That is a form of therapeutic inertia. And it doesn't have to be that overt. I've had patients that tell me that they are resistant. They don't share what's going on because they don't want to upset their doctor. Now, quite literally, this makes me tearful. It makes me super sad. But there are situations where a patient says, Dr. Boster, I don't want to disappoint you. I don't want to tell you that something bad has happened because you put me on this drug and I took the drug and it didn't work and I feel guilty. That is a form of therapeutic inertia. There are other situations with therapeutic inertia where someone has finally figured out how to make their therapy work. Whether that be a pill that causes flushing, and they finally figure out if they take a baby aspirin and they eat a big meal and they take their pill that they don't have flushing, and they're happy about that. And then they have breakthrough disease. and they don't want to change because it took them so long to figure out how to do it that they don't want to make a change. And therapeutic inertia can be subtle. Well, I just won't tell the doc, or I'll just tell them, can we please try a little bit longer? I don't want to switch just yet. But the bottom line here is that therapeutic inertia is something that patients sometimes suffer from and that they can cause. And so one of the three groups of people that are culpable in therapeutic inertia are patients. But patients are not the worst ones, all right? So patients can cause therapeutic inertia, but they're not the worst ones. The second group of people that contribute to therapeutic inertia are insurance companies. So insurance companies and third-party payers, or in some cases government payers, but most of the time in America, third-party payers, insurance companies can demand step edits. Now, a step edit says before you're allowed to take drug X, you have to take drug Y. We won't allow you to have drug A until you failed drug C. And to speak bluntly, those oftentimes are not medical comments. They're not driven by medicine. They're not driven by science. They're driven by finances. They're driven by rebates. They're driven by financial implications. And what happens is it forces someone to go on to or to suffer from a medicine that is less effective where they have breakthrough disease, even though we identify that that's not going to work for them or it's not working for them. And insurance companies, third-party payers, at times are guilty of systemic therapeutic inertia. And so therapeutic inertia, for those of you that are just jumping on, there's 115 people online. That's awesome. We're talking about therapeutic inertia and how it makes people with MS worse, how it makes people with MS lose their job, how it makes people with MS sit in a wheelchair. And therapeutic inertia is when you identify that someone with MS has gotten worse, they've had breakthrough disease despite taking a medicine, and they don't change. And thus far, I've told you about two of the three groups of people that are contributing to therapeutic inertia. The first one I talked about were patients. The second one I talked about were third-party payers, but they are not the worst. I'm about to tell you the worst group of people as it relates to therapeutic inertia, and that's doctors. That's people like me. That's clinicians taking care of folks with MS. And I'm being very serious right now because this is a super serious topic. There are a lot of pressures out there for clinicians, and I want you to walk through this with me. And it's not because doctors are dumb. It's not because doctors are lazy. It's because of lots of external pressures making things super challenging. And it breaks down like this. I take a half an hour for every follow-up patient. That's twice as often as the average doctor takes with an MS patient. The average time in the United States is 15 minutes. So I'm going to use an example of a 15-minute visit. Now, that's insane to me as is. 15 minutes to talk to a human being isn't enough time to take off your jacket, to get comfortable, and then to have just a meaningful hello, howdy, hi. And yet, that's what we've got. Now, in those 15 minutes, that doctor has to do a form of an examination probably. So they're going to have you look at some things and do an exam. They're going to review with you kind of what's going on. They're going to review with you an MRI. They're going to review with you laboratories. They have requirements in the electronic medical record where they have to type in a bunch of things and press a bunch of buttons. Now, imagine a situation where that doctor had a couple patients that needed extra time. So they're in a room for 15 minutes, except the patient needs more time, and so they spend 20 minutes. And the next patient spends 20 minutes. And the next patient spends 20 minutes. So suddenly, that doctor is a full patient behind. They're taking their 3 o'clock patient at 3:15 or 3:20, and they can't get caught up. And they have all these pressures of things they need to do, and they have to go through all these things. If they don't dive deep into how the patient's doing, if they simply say, hey, are you okay? Great, bye-bye. And they don't ask difficult questions. They don't ask about cognition, sexual function. They don't ask about depression and anxiety and sleep and bladder and bowel and falling risk. If they don't ask those questions, maybe they'll get back on time. If they don't ask how the patient's doing more than cocktail speech, well, then maybe they're not going to have to intervene, because if they identify that something's wrong, that's a lot of work and it takes time. And so if they identify that something's wrong, they're going to have to hit pause. They're going to have to talk about it. They're going to have to sort it out. They're going to have to take a more complex history. They're going to have to take a more complex exam. They're going to have to order tests, and it's going to take more time. And wouldn't it just be easier? Wouldn't it just be easier if everything would just be okay? And as a result, doctors are oftentimes to blame for therapeutic inertia, where it's easy to have a cocktail party speech. Hey, honey, you look so good. Is everything all right? Oh, great. I'm not really listening. Everything sounds fine. All super duper. And bye-bye, and I'll see you in 6 months. Oh, did you need any refills? Bye-bye, honey. Guys, this happens a lot. And therapeutic inertia leads to people with MS staying on medicines that aren't working for them, not escalating when they need to, and accruing neurological disability, accruing brain damage. And therapeutic inertia results in people with MS getting worse. So what do we do about it? Well, before I tell you, I'm going to have a little bit of water. So what do we do about therapeutic inertia? The first thing that we need to do about therapeutic inertia is we need to understand that it exists. The first thing we have to do with therapeutic inertia is we need to understand that it's out there, that it's a thing. And the second thing that we need to do when it comes to therapeutic inertia is when we see it, we need to call it out. Now, somebody's knocking at the door here, and I'm going to run to the door. No, I'm going to leave it alone. Hold on 1 second, guys. Don't go away.
Hello, housekeeping.
No, thank you.
Okay, enjoy your stay.
Sorry, guys. As I mentioned to you, I'm in a hotel in Chicago, and the door knocked, and it was someone that wanted to come in and clean the room. But I'm okay right now. I'm very busy doing a live stream with 118 people from around the world. I'm talking to my global online village. I am loving this because these are people that are impacted by MS, and I am participating in educating, empowering, and energizing people. And so I really don't have time for them to come in. So I apologize for the interruption, but I'm back. I'm talking about therapeutic inertia. I'm talking about my concerns when we identify that someone with MS isn't doing well and we don't change. I've shared with you that people that are culpable include patients. I'm being honest, guys. Patients are culpable. Third-party payers are culpable. But most importantly, doctors are culpable. And I wanted to talk about what do we do about it. So the first thing that we can do about it is we can know that it exists. I want the 117 people that are online right now to embrace the part that the knowledge that people can suffer from therapeutic inertia. I need you to know that that's a term. I need you to know that there is a risk of therapeutic inertia. Now, the second thing that I want you to do is I want you to call it out when you see it. If you are suffering from therapeutic inertia, I want you to call it out. If you're participating in therapeutic inertia, I want you to admit it to yourself. And if you identify that your clinician, that your doctor, that your nurse practitioner, that your physician's assistant is expressing therapeutic inertia, I want you to say you are contributing to therapeutic inertia. You are contributing to therapeutic inertia, and I'm not okay with that. Do you hear me? I'm not okay with that. Therapeutic inertia is not okay. No. And if it's your insurance company, if it's your wife, if it's you, we have to admit when we see it. So thank you guys for letting me chit chat with you about something that obviously gets me super fired up. It's this concept of therapeutic inertia, which can contribute to people being worse off than they should be. And I'm being very serious. And so let me know what you think about this concept of therapeutic inertia. If it's new to you, if it's something that's going to spark a concept, if you're guilty of therapeutic inertia, if your doctor is guilty of therapeutic inertia, if a third-party payer has told you that you can't escalate a drug, that's therapeutic inertia. Call it out when you see it. If we start talking about therapeutic inertia, if we start discussing therapeutic inertia, I think we can change. Now, there's 123 people online. And by the way, if you guys like this, give me a thumbs up. If you enjoy this conversation, give me a thumbs up down, and right below the screen, there's a thumbs up button. So if you're digging what we're talking about right now, hit the thumbs up for me. Now, if all 124 people on this live stream were to identify therapeutic inertia, we would change the world. Like quite literally, we would revolutionize the world, because we would start to help other people understand about therapeutic inertia. We would help other people become aware of it. And so if you're digging that concept, that's my challenge to you. Remember, this is MS Awareness Month. I am committed to jumping online multiple times this month to raise the level of awareness, to educate, to energize, to empower. And one of the things that I want you to be aware of is the concept of therapeutic inertia. So thank you for letting me talk about that. I really appreciate it. And there's a second topic that I want to talk about. But before I do, let's jump into some questions. You know that I love doing live stream Q&A. It's fun for me. It's a little bit challenging. I'm dyslexic, and so trying to read and trying to talk to you at the same time is kind of like juggling for me, but I enjoy that. So let me answer a couple live stream questions, and then there's another topic that I've prepared that I wanted to talk to you about. So let's see what we have going on here. Kelly J writes, everyone in my life, including myself, is guilty of therapeutic inertia. I haven't done anything for a little over a year. Well, Kelly, you are doing something special right now. Today, you're doing something special because you just admitted that. And so thank you. And my heart goes out to you. And I hope that you will contemplate and think about what that means. And I hope, Kelly J, that it will empower you to call it out when you see it and say, not okay, not okay. Thank you, Kelly. I really appreciate you sharing that. So Serena writes, I did not know it had a name, but I was guilty of it. I was afraid and ashamed to tell my doctor, but once I did, she was able to help me. And Kelly and Serena, you both make beautiful points. If you have contributed to therapeutic inertia, you're not a bad person. You're not like horrible and evil and you've done something. No, not at all. But it can contribute to you getting worse. And so I am grateful that you're understanding the concept. I am grateful that you are sensitized to the concept. And I challenge you to call it out and talk about it. Talk about it with your sister. Talk about it with your brother. Talk about it with your doctor. Talk about therapeutic inertia. Let's look at some other questions. Kimberly Treese writes, how long should you be on a med before you know it's working? I experienced a flare 1 month in. So that's a very, very good question. So here I am talking about therapeutic inertia, and I define something called breakthrough disease when you're taking a medicine and something bad happens. And so you've broken through the medicine, so to speak. So how long should you be on medicine? And we're talking about MS medicines. So MS medicines have a delay in their benefit. And if I speak in gross generalities, I think it takes 6 to 12 months to figure out if a drug's working. It can take 6 to 12 months before a drug is fully active. The fastest disease-modifying therapies, the very fastest onset is about 3 months. So when you look at clinical trials and you look at someone taking placebo and someone taking a drug, and you look at how they do, the curves split at about 3 months for the fastest drugs. There's other drugs that take 6 months. There's other drugs that take 9 months. And so if you're taking a medicine and then you have an attack the next month, it's probably too early. And so that is a very important question. And I want you to talk to your MS provider and say, hey, how long do I need to be on this before I think it's working? But as a general rule, at least 6 months for most drugs. Excellent question. Thank you for asking it. Let's take another one. Let's see, what do we have here? So Edie Coleman writes, lucky enough to be a patient at Ohio Health after seeing a general neuro. My first visit, I spent over 3 hours checking me out and getting me on track to see my second year relapse. Thank you to Dr. Nicholas and Dr. Boster. Well, Edie, we love you. We are delighted that we get to be part of your village. We are delighted that we get to try to help you. And thank you for the shout out. Thank you for supporting us, and we support you. And it is a group effort. And we are village members with you, and you are our village member. And together we will kick MS in the teeth. Many of you know that I like to wear cowboy boots. And people say, why do you wear cowboy boots? And maybe one day on a live stream, I'll tell you that story. But sometimes tongue in cheek, I say I do it so I can kick MS in the teeth with my boots. So a couple other questions. So Scott Davison writes, been very nervous about rituximab. Want some reassurance. So rituximab is an IV infusion. It's a monoclonal antibody. It's a B-cell killer. It's taken through the vein. It's taken about every 6 months. And rituximab is a highly effective medicine. I think rituximab is fantastic. It's not on a label in the United States, which means that through insurance companies, it's hard to get. It is a very, very effective drug. I've used it for years. I really, really like it. There's an FDA-approved drug, which is called ocrelizumab, which is kind of a cousin of rituximab. And that's on label, and we use that a lot these days. We use that more than Rituxan because it's available through insurance carriers and through third-party payers because it's on label. But I'll tell you, Rituxan is a baller drug. Rituxan's a really, really good drug. And so I think that you should feel very positive about doing that. The safety and side effect profile of Rituxan is pretty solid. You can have infusion reactions, and so you want to make sure that you're being infused in a place that knows what they're doing. There aren't a lot of labs that are required for Rituxan, and there's not a lot of side effects. And so I think that you've kind of stumbled upon or chosen or are about to embark on a highly effective therapy, and I think that you should feel powerful about that. Kim writes, wore my cowboy boots to my first infusion for the same reason, kicking MS. Boom. Elbow to MS's face. I love that. Maybe one day we'll do something fun where I'll challenge everyone to wear cowboy boots and take pictures and throw posts up on Twitter and Facebook. That would be a fun idea to do that sometime. All right, let's take another couple questions, and then I want to talk about yet another topic. Verna writes in, finished Lemtrada, doing well. Is there something new I should consider to stay preventative? Verna, yes, there is, because taking an MS medicine is one of 4 things that slow down MS. Now, you've taken one of my favorite MS medicines. Lemtrada is a highly effective therapy, and it's one of the most effective therapies we have. So good job. That's awesome. But that's one of 4 things. And many of you that follow me on my channel, or many of you that are involved in my clinic know that I believe in this concept of being 4 for 4 in your fight against MS. So being 4 for 4 in your fight against MS involves taking a medicine, but it also involves not smoking cigarettes, because smoking cigarettes speeds up MS. The third thing is diet. And so I talk about supplementing low levels of vitamin D. For some people, we take extra biotin. I just did a video this week where I talked about eating whole foods and staying away from processed foods and sugar. And so the third thing is diet. The fourth thing is to exercise as part of your lifestyle. So you've taken Lemtrada. That is awesome sauce. That's good stuff. That's one of 4 things. I need you to take the Lemtrada. You've done that. Good job. I need you to make sure that you're not smoking cigarettes because that speeds up your MS. I need you to concentrate on diet, specifically supplementing low levels of vitamin D and exercise as part of your lifestyle. Those are 4 things that you can do, and you can be 4 for 4 in your fight against MS. So that was a great question, and thank you for asking it. All right. Shell Z writes, yes, challenge the cowboy and cowgirls. So maybe we're going to do something fun. She recommends that we maybe have like a donation link. So I'm going to have to think about that. And maybe we'll come back and we'll have the cowboy boot challenge to kick MS in the butt. That sounds like a lot of fun. All right. So I've got Andrew C. from England. Should bladder control medicines slow my walking? Walking improves when I reluctantly stop bladder medication. That's really interesting. So Andrew shares that he feels that when he takes a bladder medicine, it impairs his walking. And that's fascinating. Now, Andrew, you're not a textbook, and you're not a group of people. And maybe for you, when you take a bladder medicine, it impairs your walking. And I would bring that up to my MS provider. Andrew, if my patient came to me and said that, I would want to do an experiment. I would do an experiment where I would time their walking. I might even have them come in once a week just to do a walking test, just a quick walking test. And after they did a quick walking test on a medicine, then maybe I would have them stop the medicine. I would have them stop the medicine and then come in once a week and do some walking tests to find out if, in fact, you're right. Yeah. To find out if, in fact, the medicine was impacting their walking. Because, again, you're not a textbook. You're a human being, and it is possible that it could impair your walking. There are 133 people online. That is freaking awesome. There's 84 thumbs up. If you guys are liking this interaction, then give it a thumbs up. We've talked about so far therapeutic inertia. If you're just jumping online right now and you missed that discussion, please check it out in the replay. We talked about wearing cowboy boots in clinic and kicking MS in the butt. And maybe that's going to spur us to have a challenge where we're going to challenge people to take pictures of cowboy boots and with the idea of kicking MS in the butt. And before I jump off the line today, I want to talk about one more topic. So there's one more topic that I'm hopeful that we can talk about today, and that is treatment style. Treatment style. What do I mean by treatment style? Well, style can apply to a lot of things. So you can have fashion style, right? You can have style when you present, when you're up on a stage. There's a lot of different styles. I'm talking about treatment style, and I'm talking about the style of treatment that your MS neurologist uses. I'm talking about the style of treatment that your clinician uses. And there are different styles or different treatment approaches. Now, the reason this is really important is it has a major impact on which medicines that you are offered and how those medicines are used. And if you're not aware of your doctor's treatment style, or if your doctor's not aware of your doctor's treatment style, that puts you at a grave disadvantage. And so I want to spend a few minutes talking to you guys about the concept of treatment style. And so the first treatment style that I'll talk about is one and done. There are some doctors out there taking care of MS patients where every patient goes on one drug. I put you on that drug and I'm done. That's what I do, and I don't change it. And if you have something happening, whatever, one and done. Now, you guys can imagine that Dr. B does not like the one and done treatment style. To me, I think that has a lot to do with therapeutic inertia. I think that's bad, but it is a treatment style. And if your clinician has a one and done style, I want you to know that. I want them to know that. And so I hope that people don't have a one and done treatment style, but if you identify that, I want you to be aware of it, and I want you to call it out when you see it in the same way that I want you to call out therapeutic inertia. Now, the second treatment style that I'm going to talk about is escalation, a slow escalator. So the slow escalator is a doctor that puts someone on a medicine, and then maybe if the person does bad, they'll escalate to something that's more effective, but they don't do it quickly. It's going to take a tremendous amount of bad things happening before that provider is willing to escalate to a different therapy. And those people are called slow escalators. And I am not a fan of slow escalation. As you can imagine, slow escalation is a form of therapeutic inertia, and it allows people with MS to accrue disability. It allows people with MS to get worse because you're allowing not just one hit, but multiple different bad things happening, multiple different episodes of breakthrough disease, despite being on a medicine that's not working before you escalate. And there are many, many people out there, doctors that practice the slow escalation model, which I don't like very much. Now, there are other styles of treatment. There are other styles of treatment where people are fast escalators. So they start someone on a low efficacy medicine, but the moment something bad happens, they escalate. The moment they have something bad happen, they escalate. So one attack and we switch drugs. One new spot and we switch drugs. Fail the litmus test of life, we switch drugs. And so that's a style of treatment. Slow escalation, high escalation, fast escalation. So in talking about styles of treatment, we've talked about one and done. We've talked about slow escalators, and we've talked about fast escalators. And then I want to talk about induction therapy. Induction therapy is a style where I hit you with a very heavy hitting drug up front, and it resets the clock, it reconstitutes the immune system, it reboots the immune system, and then afterwards, we hope that the disease is quieter. And so induction therapy is different. Induction therapy is different than one and done, slow or fast escalation. And I'll throw up another form of style, and that is de-escalation. So de-escalation, in my opinion, would be starting with induction and then maintaining the person on a lower efficacy medicine. Now, I have opinions, and you guys, by listening, can probably sort out what my opinions are. But my point is not that I'm right and you're wrong, or I'm right and they're wrong. That's not what I'm saying. I instead want to sensitize you that there are different styles of treatment. And in the same way that I want you guys to become aware of therapeutic inertia, I also want you to become aware of the treatment style of your clinician. And if you disagree with the treatment style or you agree with the treatment style, it's a good thing to talk about. In the same way that I want you to call out when you see therapeutic inertia, I want you to call out, hey, are you a slow escalator? Or is it going to take me losing my leg before you'll change my drug? And these are things that I think are really important. The reason I think that they're really important is because it can result in an outcome that you don't want. These concepts, guys, are not commonly taught in medical school. And they're not commonly discussed in the clinic, and yet they have a major impact on people impacted by MS. They have a major impact in your quality of life, and they have a major impact in the trajectory of your disease. So thank you for letting me talk about that. It is MS Awareness Month, and I have committed to jumping online to live stream multiple times this month. I really hope you guys are getting tired of it. In fact, if you think that I'm doing this too often this month, please leave a comment and say, hey, Dr. B, back off a little bit. You're overwhelming us. Let me know, because I certainly don't want to do that. But what I do want to do is I want to empower you. I want to help educate you. And I want to help energize you. I want you to wear proverbial cowboy boots and kick MS in the teeth. So elbow to MS's face. My name's Aaron Boster, and thank you for learning about MS with me. I mean, we've been online for 37 minutes, guys. We have 123 people that have jumped online. What an amazing global village. I am overwhelmed, and there's 100 thumbs up. I'm loving this. Thank you very much. It means the world to me, and I hope that today's messaging, today's discussion about therapeutic inertia and about the fact that patients, payers, and providers are all culpable in dealing with therapeutic inertia is something that is educational to you and helps sensitize you and helps you fight back. I also hope that my discussion of different therapy styles, one and done, slow escalation, fast escalation, induction, and de-escalation are things that are provocative thoughts for you and that will help you better understand the playing field and how you're being treated. Until my next video or my next live stream, thank you guys. I love you all. I love this online community. You guys mean the world to me. And so until my next video or my next live stream, this is Aaron Boster saying take care and have a great night.